Greetings to all the PhysioTV viewers. I am Dr. Aditee Mangaonkar, a final year MPT student from Sanchet Institute for Orthopaedics and Rehabilitation College of Physiotherapy. I'm specializing in musculoskeletal physiotherapy. So today we'll be learning about the various hand deformities seen in rheumatoid arthritis. So let me just share my screen. So the objectives for the seminar or the discussion will be to understand the biomechanics of the hand, specifically related to the deformities seen in RA. Then the various deformities seen in RA in the hand and wrist, and the pathomechanics of these deformities and the management of these deformities. So firstly, we'll be seeing the flexor aspect of the hand. We all know that there are extrinsic muscles and intrinsic muscles. So the extrinsic muscles are the muscles that originate beyond or proximal to the wrist from the medial epicondyle of the humerus and go and insert into the hand. So the FDS, that is the flexor digitorum superficialis, the flexor digitorum profundus, and the flexor pollicis longus are the extrinsic muscles of the hand. Then the intrinsic muscles are the thenar muscles, hypothenar muscles, and the lumbricals and the interossei. So in the thenar muscles, as we can see here, we have the flexor pollicis brevis, abductor pollicis brevis, and the opponens pollicis. And for the hypothenar muscles, there is flexor digiti minimi, abductor digiti minimi, and opponens digiti minimi. All these muscles originate in the hand, that is distal to the wrist, and insert in the hand itself, hence called as the intrinsic musculature of the hand. We'll see the importance of these muscles later on. The other muscles are the lumbrical muscles and the interossei muscles, the palmar and the dorsal interossei, which are more seen in the extensor aspect. There are synovial sheaths present in the palmar aspect, the ulnar synovial sheath, and the flexor tendon sheaths, which are wrapped up around the flexor tendons of the long finger flexors, the FDS and the FDP and the FPL. Also, there are pulleys, which are a fibro-osseous tunnel, which is formed over these sheaths of the tendons, and they prevent the bowstringing effect of the tendons when the action is being performed, such as gripping or flexion of the fingers. In the extensor aspect, we have the major extrinsic muscles, that is the extensor digitorum communis, the extensor pollicis longus, and the extensor indicis. So all these muscles get originated from the lateral epicondyle of the humerus and get inserted in the hand beyond the wrist joint, hence called as the extrinsic muscles again. These muscles get inserted in the wrist, and then from there the tendons get split into the hand, called as the extensor expansion of the hand. So this is the extensor aponeurosis or the dorsal aponeurosis of the hand. So here we will see that the EDC muscle, that is the extensor digitorum communis muscle, inserts in the wrist, and from there 4 slips of the tendon get divided over each metacarpal respectively here. And from here, at the MCP, it gets expanded with the dorsal hood, which is the expansion of the extensor aponeurosis. This again prevents the bowstringing effect of the tendon. From here, the EDC tendon, which was inserted over the MCP, gets divided into 3 major tendons. First is the central tendon, which gets inserted just beyond the PIP over the middle phalanx. Then there are 2 lateral bands which get inserted from which get originated from the MCP and go dorsally and laterally and get inserted just before the DIP to form a terminal tendon, and the terminal tendon gets inserted on the distal phalanx just after the DIP. So this helps in extending the DIP joint. In the extensor expansion, we have active components and the passive components. So in this figure, we can see all the passive components. Here, we have the dorsal hood, the sagittal bands, and the triangular ligament. These are the major passive components in the expansion. So the triangular ligament is seen just on the middle phalanx. It connects the lateral bands together and prevents the subluxation of these bands laterally, further laterally, and also connects it to the bone, that is the proximal phalanx, uh, with the bands. And then we have the sagittal bands, which are present over the MCP joint uh, along with the dorsal hood. So the sagittal bands also prevent the bowstringing of the tendons, and they connect the extensor aspect to the volar plate, which is present volarly on the palmar aspect. And then there is a deep transverse metacarpal ligament along with the dorsal hood. Now in the active component, we have the three major intrinsic muscles, that is the palmar introssi, dorsal introssi, and the lumbrical muscles. The palmar introssi and the dorsal introssi originate from the metacarpals and get inserted laterally to the central tendon, just near the proximal phalanx. And the lumbricals, which get originated from the flexor digitorum profundus muscle in the hand, get inserted here to the lateral bands and the central tendon at the middle phalanx. So these three muscles are important in maintaining the extension of the IP joints. Along with that, we have one more passive component, that is the oblique retinacular ligament. This originates from the annular and cruciate pulleys from the flexor aspect. They go slightly volarly and distally near the PIP joint. And from there, they traverse dorsally and laterally to insert near the terminal tendon. So this oblique retinacular ligament has the line of force volar to the PIP joint and dorsal to the DIP joint. The functions of the extensor expansion of the hand are force transmission from the extensor digitorum communis to distally to all the fingers, then to bring about the functional movements by improving the efficiency and gliding of the muscles and tendons respectively. And the oblique retinacular ligament, which is very important, helps in interdependent movement of the PIP and DIP extension. So if the oblique retinacular ligament is tight, it leads to deformities, most commonly the boutonniere deformity. We'll see that in detail further. Now, in rheumatoid arthritis, we all know that it is a chronic systemic inflammatory disorder which affects the synovial tissue. It causes synovial hypertrophy, that is, the synovial hyperplasia will cause the distension of the joint capsule and all the surrounding soft tissue, that is the tendons, ligaments, and which can further lead to its injury or a tear or a rupture, and this leads to joint instability, further causing deformities. So this joint destruction is a result of the interaction between the decreased synovial tissue and the normal joint tissue. And as the disease progresses and becomes chronic, it gets fibrotic and leads to permanent deformities and contractures. The factors affecting the finger deformities are the joint synovitis, then the wrist deformities that we'll see in detail, the intrinsic muscle imbalance, the imbalance between the introssi and lumbrical muscles, and the imbalance of the flexor and extensor tendon forces of the extrinsic tendons. So we all know that because of the synovial hyperplasia, it affects the tendons, ligaments, and the muscle. So it affects the normal, it disrupts the normal architecture of the tendon and leads to loss of the normal tendon function. And the tendon rupture is as a result of the tendon weakening, which can lead to a rupture. So as the pressure on the tendon increases due to the synovitis, there can be reduced blood supply to it. And again, because of the compression and reduced blood supply, there can be a ischemic rupture of the tendon as well. And on the muscle, the intrinsic musculature gets fibrotic and tight, and therefore it can lead to further deformities. These are the most common deformities seen in the hand. First is the boutonniere deformity. Second is the swan neck deformity. Then is the ulnar drift at the metacarpophalangeal joint and the palmar dislocation at the metacarpophalangeal joint. We'll see all of these and the pathomechanics in detail. At the wrist joint, we have various deformities seen. Firstly, at the scapholunate ligament. So at the scapholunate joint, the scapholunate ligament gets affected because of the chronic synovitis, and there is instability because of the weakness of the scapholunate ligament. This causes the scaphoid to go into further flexion position and in a palmar position. So there is radial deviation of the carpals and the metacarpal on the radius. So it moves in the radial aspect. Therefore, there is loss of the carpal height, and this causes imbalance of the extrinsic muscles and leads to an extrinsic minus or an intrinsic plus position. Now, the radioscaphocapitate joint. Here, the radioscaphocapitate ligament is affected. This ligament is attached proximally to the radial styloid and goes on the volar aspect to attach on the scaphoid and then the head of the capitate. So if this gets ruptured, there is disruption in the architecture of the carpals and can lead to a carpal collapse, leading to wrist instability and further contributing to the vertical rotation of the scaphoid. Therefore, there is carpal subluxation. Also on the ulnar side, because of the ulnocarpal ligaments or the triangular fibrocartilaginous structures getting disrupted due to the synovitis, there is volar subluxation of the carpals and supination of the ulnar carpals. This causes further imbalance of the extensor tendons and causes the carpals to shift radially. Therefore, there is compensatory ulnar deviation of the finger seen, and the zigzag collapse is seen in the hand. At the distal radioulnar joint, we can see that there is a dorsal subluxation of the distal ulna. This is because the distal radioulnar ligaments and the TFCC is getting affected or injured or ruptured. So there is dorsal tenosynovitis of the sixth extensor compartment, that is the extensor carpi ulnaris tendon, whose function is basically to extend and ulnarly deviate the wrist and provide stability to the wrist. However, because of the affection of these ligaments, this extensor carpi ulnaris tendon shifts volarly and acts as a flexor, increasing the deformity. And therefore, there is unopposed radial deviation forces and causes ulnar carpal subluxation. There is also ulnar translocation because of the destruction of the radiolunate ligaments, and hence leads to ulnar deviation. So the piano key sign or the floating ulnar styloid is therefore seen as the ulnar styloid is more prominent. At the MCP joint, we have two common deformities. First is the palmar subluxation. Because of the unopposed or while gripping, there is unopposed forces of the FDS and FDP acting at the MCP, PIP and DIP. So while flexing, there is increased force at the MCP, which is commonly prevented in a normal tissue by the A1 pulleys that we had seen before. So the pulleys prevent the bowstringing effect of the tendons over the metacarpals. So in case of disease where because of the chronic synovitis, there is a tear or rupture of the pulleys, there is going to be bowstringing effect caused at the MCP joint, and this causes increased forces at the MCP, leading to proximal subluxation of the proximal phalanx over the metacarpal. And along with that, there is ulnar drift present. So at the MCP joint, which is ulnar drift is seen after there is proximal phalanx subluxation because of the forces of the gravity acting on it, or because of the line of pull of the extensor tendons, which gets subluxated ulnarly because of the deformities, and because of the asymmetry of the metacarpal heads. Because of all these reasons, there is ulnar deviation forces already present. Along with that, all the functional activities such as gripping leads to increased ulnar deviation forces on the hand, especially at the MCP. Thus, there is a bowstringing force at the MCP, which is prevented by an intact, healthy soft tissues, that is the radial collateral ligament and the dorsal hood. But as the radial collateral ligament and the dorsal hood is ruptured, the forces go on ulnarly and causes a bowstringing effect, increasing the ulnar deformity. So as the disease progresses and as in how we use the hand more for gripping activities, there's constantly going to be loading and increase in the ulnar drift of the metacarpals, the metacarpal carpophalangeal joint. Now, we will see the zigzag deformities of the fingers. The most common is the swan neck deformity. Here, we can see that the MCP is in flexion, the PIP is in hyperextension, and the DIP is in flexion. So there are three mechanisms of the deformity to get developed. It can originate from abnormalities at the MCP, at the PIP, or at the DIP. So firstly, let's see the mechanism, how it is formed because of the affection at the DIP. The central tendon and the terminal tendon, which gets attached at the DIP, beyond the DIP joint, gets ruptured, which causes flexion at the DIP joint. Hence, the forces are acting more at the PIP joint. This causes hyperextension at the PIP, since the action of the central tendon and lateral tendon was extension at IP joints. This causes further volar laxity or the overstretching of the palmar plate and further causes increase in the hyperextension at PIP. And as a compensatory mechanism, there is flexion at the MCP joint, since there is loss of flexion at PIP joint. Further to it, if the let's see if there is affection or abnormality at the PIP joint. Because of the chronic synovitis, there is overstretching of the ligaments and capsule. This stretches the volar capsule and leads to PIP hyperextension. Because of the hyperextension, these lateral tendons are going to displace dorsally further and further increase the hyperextension at the PIP joint. And because of this, there is compensatory DIP flexion, as there is constant pull of the flexor digitorum profundus, which is unopposed by the ruptured extensor tendons. And the third mechanism is if the MCP joint is affected commonly. So because of the palmar subluxation and ulnar deviation that we had seen in the MCP joint before, there's going to be increased tension in the intrinsic musculature, which were the lumbricals and the interossei. The action of it was bringing about extension at the IP joints. So if the lumbrical muscles are overactive, they're going to pull the PIP joint into further extension. And because of this, there is going to be compensatory DIP and MCP flexion. So these are the three mechanisms of the deformity to be formed for the swan neck. Secondly, we have the boutonniere deformity, which is second common. Here, it is exactly the opposite of swan neck. There is a PIP joint flexion and DIP joint hyperextension. Okay, so let's see that in detail. In boutonniere, this deformity always starts at PIP joint and never at the DIP. Because of the affection of PIP in RA, there's going to be rupture of the central slip, which was inserted on the middle phalanx. This causes flexion at the PIP joint. And this causes, because of the flexion of the PIP joint, the lateral bands get displaced volarly, and the function of the lateral band was to bring about extension. Because it is now shifted volarly, it is going to bring about hyperextension at the DIP. And because of this, the oblique retinacular ligament is going to be pulling the distal phalanx down and causing tightness, and hence leads to deformity at the DIP as DIP hyperextension and PIP flexion. And there is compensatory MCP extension seen. Now at the thumb, there is a zigzag deformity seen. So here, it originates basically at the CMC joint, that is the metacarpal joint involving the trapezium and the first metacarpal. Here, the radial collateral ligament and the anterior capsule is affected. So if there is a rupture or tear of the radial collateral and the anterior capsule, there's going to be subluxation of the metacarpal on the more towards the palm. that is ulnarly. Hence, there's going to be constant tightness of the flexors and the adductors of the thumb. So because of this tightness, which can further lead to a fibrosis in the muscle, there's going to be to compensate for the extension loss in the thumb at the CMC, there's going to be MCP hyperextension. So because of the uh, CMC going into flexion, there's going to be constant MCP hyperextension. Further, there is more pull of the extensor pollicis longus, which is getting unopposed because of the overstretched palmar plate at the MCP joint. Hence, increasing the concentration of the forces at the PI. So there is overstretching of the palmar plate, and because of the constant force, there's going to be a flexor pollicis longus which is getting taut, causing the IP into flexion. So the deformity is IP flexion, MCP extension, and CMC flexion. This is the zigzag deformity. Now, the effect of synovitis on the extensor tendons is that these tendons can get ruptured because of the ischemic compression and leading to ischemia, or also because of the attrition, that is the tendon getting rubbed over the roughened bone because of the chronic synovitis. These can lead to tears, and there is subluxation of the extensor tendons ulnarly, as we had seen before. Also, the sagittal bands and the junctural tendini, which hold on the extensor tendons, get disrupted, leading to subluxation of these tendons, further increasing the deformity into ulnar deformity. Then, in the tenosynovitis, because of the tendon compression and weakening, there's reduced blood supply, leading to tendon rupture. Most commonly affected are the extensor pollicis longus, and in the flexor aspect, we have the flexor pollicis longus and the index finger long finger flexors, that is the FDS and the FTP. It can also lead to a trigger finger where there's an inflammation and leading to a nodule formation in the synovial sheath and in the pulleys getting fibrotic, further disrupting the gliding of the tendon and causing a snapping sound on flexion and extension. Lastly, we have the Vaughan-Jackson deformity. So here we can see in this diagram that there is a rupture of the extensor tendons in the third, fourth, and fifth digits, which leads to inability to extend these fingers. So chronically, the tenosynovial inflammation at the wrist joint and the chronic rubbing of these tendons along with the damaged ulnar styloid is going to lead to the rupture at the wrist. Hence, completely, it is not possible to extend these three fingers at all. This is a surgical emergency and has to be treated the same. Let's see the management of the deformities. Along with the medical management, joint protection techniques are very important, which are going to reduce the forces over the damaged soft tissue. So we have most commonly used are the finger and wrist orthoses. So these are going to maintain the joints into neutral position and give support to it. So because it is maintained in a constant neutral position, it can help in reducing inflammation, and it prevents deformities and maintains the joint alignment. As it is giving a constant support, it can help in reducing pain and improving the function. The wrist orthosis can be also used for maintaining the stability at the joint and improving the function. This is a overlaid ring finger splint given for the deformities at the IP joints. And this is the splint to reduce the ulnar forces on the MCP. So this pull is towards the radial side. This can be used to improve the function of gripping. Next, we have activity and environmental modifications. So in rheumatoid arthritis, we all know that activity modification is really important. We should avoid activities that can aggravate the MCP ulnar deviation and increase the force distribution more on the ulnar aspect. So activity pacing and using the larger joints is more important. So using the wrist or the heel of the hand to open or close a jar, or pushing or pushing a door with the shoulders instead of using the hands to pull or push the doors. Then stirring with the forearm in neutral position instead of using a lot of gripping and ulnar deviation, we can also have use both the hands to lift a glass or lift objects. And we can also use shoulder bags instead of holding a briefcase or a shopping bag, because that is going to constantly increase the force on the smaller joints. Adaptive devices can also be used to increase the leverage and distribute the forces equally at the larger joints. So the spoons or the utensils or even pens can have a larger diameter grip. So to prevent a lot of pinching, which can aggravate the deformity. And a modification of the spoon can also be used if gripping or pinching is not possible at all. Along with this, we also have to recommend them exercises, but they have to be designed in such a way that they will avoid or prevent the deforming forces on the flexor tendons especially, and the metacarpal ulnar deviation. So all the exercises that can help in improving the stability of the joint are really important. These are my references for the today's discussion. Thank you so much. Thanks to PhysioTV team, Dr. Parag sir and Manisha ma'am, for giving me this opportunity and sharing this knowledge with you. Thank you.